Wow, that was loud. All right, so we're gonna do renal. And like I said, focusing mostly on the major ones, acute and chronic, because those are the more like complicated ones. So start with the basics, kind of set ourselves up here. So the kidney does a lot, right? It does a lot of functions, super important. Does a lot more than just make pee, right? So what are some functions you guys can list off the top of your head?
Produces erythropoietin.
All right, erythropoietin. There we go. Poietin. And what is that? Yeah, so it goes, I think it's hormone that goes to the bone marrow and tells the bone marrow to produce red blood cells. That's where we get the word erythrocyte from. You remember that from A&P? They called the red blood cells the erythrocytes. So that's red blood cells. And if the kidney is damaged and can't produce erythropoietin, what's that going to do to your red blood cell count? Decrease. Right, so your H&H is going to go down. And what kind of signs and symptoms would you have with low H&H?
Fatigue.
Same signs like anemia, right? So like you got the fatigue, lethargy, dizziness, activity intolerance because you're just low on iron, and the red blood cells carry what on them to your body? Oxygen. So it makes you feel like you're just really out of breath, out of shape. Okay, what else?
The vitamin D.
Right, so that's a really long word that I'm not going to write, but that's the hormone dihydroxycholecalciferol. Say that 10 times fast. We'll just put vitamin D instead. So vitamin D, essentially production. And what other vitamin, I guess, correlates with vitamin D? Calcium. So what does that have to do with calcium?
It decreases when there's not enough vitamin D being made.
Yeah, the vitamin D and the calcium, they need each other to absorb. So if there's no vitamin D in your body, then you're not going to absorb calcium, right? So you have to have the vitamin D to absorb it. So no vitamin D means low calcium. What's the other one that has to do with calcium? Phosphate. Phosphorus, phosphate. So there's like a, what do you call it when there's a relationship between three people? Anyways, it's like this complicated, like three relationship thing. A love triangle. That's what it is. A love triangle. I was like, it's this. I couldn't think of the word. Yeah, so you have to have vitamin D to absorb calcium. No vitamin D means you're going to have low calcium. And calcium and phosphorus are always opposites in balance. So if your calcium is low, then what's your phosphorus going to be? High. And so that's how you end up with, like, one of the signs and symptoms of kidney failure is hyperphosphatemia. And you're like, wait, why? Like, what does that have to do with anything? It goes backwards. It goes back to the low calcium because there's no vitamin D. All right, what else?
Filters waste products.
Filters waste.
Maintains acid base.
Let's just stick with this one first. So the kidneys are damaged. Sorry about the squeaky. It's super squeaky. Filters waste. Let's just say the kidney's damaged and it's not filtering waste as well. You're gonna have all these toxins floating around your body, right? What problems are you gonna have? It's got all sorts of junk floating around in your bloodstream that can't get out.
Did that cause like edema or anything?
Well, indirectly, I'm thinking more like kind of signs and symptoms like either uremic frost. Did you ever hear about that? Did she show you pictures of it?
Yeah. Yes.
It's weird, isn't it? Like your skin and your pores just start like oozing this weird, like, I don't even know what you would explain it. It's like this like substance that you're just excreting. So things like, uremic frost. I don't even know if you can read this on the video or not. Sort of. I just write too small. What if these toxins get to your brain? What's that going to do to your mental status?
Decrease.
Yeah, so have you ever heard of like encephalopathy related to kidney issues? Like people just literally go crazy because of all the toxins floating around. So they can get encephalopathy. I think your notes maybe say like confusion, or lethargy. All that is like mental related. You just got all this like literal waste products floating around your body that can't get out because the kidney's not working, right? So that's a problem. Other signs and symptoms you might have related to that would be, let's see.
Uremic halitosis.
Yeah, that's the one. That was like, what's the word? Uremic halitosis. And what is that? Pea breath. Yeah, actually, halitosis is bad breath. It's just like you smell that toxins in there. There are a couple words that we might want to know that relate to this. One is azotemia. Remember that one?
Yeah.
What is that?
The accumulation of the waste products.
Yeah, so the waste products are increased, right? And what about uremia? What's the difference?
It's got the symptoms.
Right, so it's the presence of the toxins, but it's to the point where it's so bad that now you have signs and symptoms, which are the ones that we kind of listed right here, right? So this is just, it's kind of like you don't worry about bradycardia unless you have symptoms, right? So it's like you're not super worried about azotemia unless you have symptoms. That's uremia, kind of like that. Is this helping, like clearing some of these out, how these relate? Okay, what are some other ones, other functions?
The acid-base balance.
Acid-base. Fun, our favorite thing, right? So how does the acid-base balance relate to the kidney? And it's okay if you don't know.
I just know when they're not functioning, you go into metabolic acidosis.
Yes, you do go into metabolic acidosis when it's not functioning. But the reason is because, if I sit, can you sit? Yes. I'm just trying to be aware of the video as well I'm talking. So when the kidney is damaged, it's not able to reabsorb or produce bicarb. Remember bicarb? And bicarb is a what? Is it acid or base? Base. It starts with a B, that's how I remember it. Bicarb is a base, B and B, right? Simple way to remember. So if the kidney is not able to reabsorb a base or produce bicarb, which is a base, how is that going to affect the pH scale?
It goes down, like to where it's acidic.
Right, you're going to become more acidic, right? Does that make sense? Now, a bunch of stuff happens when you're in acidosis, which we'll get to. The other part is with the hydrogen ions. The hydrogen ions are, I don't know how in depth I go into this in your notes or how much you need to know, but just know that a hydrogen is the acid. Because if they ask you about hydrogen and bicarb and the relation, bicarb is the base and hydrogen is the acid. And so when you're in acidosis, what kind of signs and symptoms do you see in a patient? About something with breathing.
You're breathing more fast.
What's it called?
Hypoxia.
Starts with the K.
Oh,
Q-smalls. Yeah. Fun, fancy nursing term, Q-smalls. And what is Q-smalls? You said the rapidly breathing, like super deep, like it's like kind of gaspy.
Breath.
Yeah. So Q-smalls, the reason why your body starts doing Q-smalls is because when you're breathing deeper and faster, you're getting rid of carbon dioxide faster, right?
And doesn't it happen a lot with like DKA?
Yeah. So DKA can put you into acidosis as well. So there's different things that can put you into acidosis. So the signs and symptoms of acidosis are going to be the same. If that makes sense. Yeah. So Q-smalls gets rid of your carbon dioxide faster. And carbon dioxide is, take a guess, is it acid or base? If your body's trying to get rid of it, it's an acid, right? So it's acidic. So these are kind of things your body's trying to do to compensate. So your kidney's damaged, it's not able to produce or reabsorb bicarb, which is a base, so the balance gets out of whack, right? You're still producing all the hydrogen, still producing the hydrogen, whatever. So the acid is there, but the base isn't there to balance it out. So you're like, okay, what can my body do to help get rid of some acid? And you start doing Q-smalls, breathing faster to get rid of more carbon dioxide out of your body. Does that help make sense? All right, I think there's a couple more functions, and we'll get to the heavy stuff.
The RAS system.
Yeah, so that's part of regulating blood pressure, right? So regulate blood pressure. And you said through the ROS. Do we need a Do we need a revisiting of the Ross?
Like the sodium retention, right? That happens.
I'll just do a real quick like recap of the Ross, just so it's somewhere in your brain. You don't need to know like all the super in depth. Okay, so the renin, angiotensin, aldosterone system. So the kidneys will produce the renin, right? Kidneys produce renin, which then you'll have angiotensin 1. And where does angiotensin 1 need to go to turn into angiotensin 2? Angiotensin is floating around in your bloodstream, goes to a certain organ in your body. I don't know if I can draw this. Every time I try to draw these, it looks funny. These are supposed to be lungs. I just need to Google a picture. So angiotensin 1 is floating around your bloodstream. It goes to the lungs. I'll just write that so I don't get confused. And inside the lungs, there's a certain enzyme. Do you remember what that's called? Angiotensin converting enzyme, right? So this is where we get ACE inhibitors from. Angiotensin converting enzyme converts angiotensin, right? So it converts it from Ang1 to Ang2. And why do we care about Ang2? What does Ang2 do? It increases your blood pressure by vasoconstriction. So you know, like if you have vasoconstriction, you ever like had you ever done gardening with a hose? You know, like the opening of the hose, when you turn the hose on, it just kind of trickles out. But if you like press your thumb over the end of it, the water spurts out faster. You ever seen that? So like what you're doing essentially is constricting, like falsely constricting the opening of the hose by putting your thumb over it, making that opening more narrow, which increases the pressure, right? So when your vessels constrict, it increases the pressure. So this is what the kidney does to increase the blood pressure. It gives, the renin, the angiotensin 1, the lungs convert it to angiotensin 2, which is the vasoconstrictor, which increases the blood pressure. And then there's also the aldosterone. Remember what aldosterone does? So these two things, it increases the blood pressure in 2 ways. Number 1, by vasoconstricting, and number 2 with aldosterone. Aldosterone does something with sodium. Do you remember?
Retention.
Yeah, so it retains or increases sodium. And what relationship does sodium and water have with each other? They're buddies. So wherever sodium goes, that's where water is going to go. They love each other. Sodium loves H2O. So if you're reabsorbing more sodium back into your body, where's the water going to go? Back into your body, right? So if your sodium is increased, then your H2O is going to increase. And when you have more volume inside of your body, what does that do to your blood pressure? Increases, right? So more volume means more pressure. It's like a water balloon. You put more water in a water balloon, the pressure is bigger, right? So increased volume increases blood pressure, right? Does that make sense? So there's 2 ways. Your body's like, okay, you need to increase the blood pressure for whatever reason. Maybe you're dehydrated, or maybe you're hemorrhaging, or like whatever reason your blood pressure is low. Your body's like, okay, kidneys, start the renin, angiotensin, aldosterone system to get that blood pressure up. So the first way is at the vasoconstriction. The second way is with sodium retention, which makes the water go up. So that tells your kidneys, hey, if we're going to reabsorb water, because we're reabsorbing sodium, that means we're not going to be peeing it out, right? Because whatever you pee out isn't getting put back into your body, obviously. Does that make sense? So that's how it regulates blood pressure. I think is that all of the functions? I'm not sure if we hit them all. Fluid balance, urine and sodium, blood pressure, acid base, waste, erythropoietin, vitamin D. Yeah, okay, so those are the functions. Did anybody want to take a picture of this before I erase it? You got it? Okay. I think I'm going to switch to the red marker because it shows up way better than the black one. I'm we erase this now. And this is why ACE inhibitors decrease blood pressure, right? Because if you inhibit the angiotensin converting enzyme, then angiotensin 1 can never convert to angiotensin 2, which means you never have the vasoconstriction, so you don't have the increase in blood pressure. Yes, okay. I'm gonna leave. Does anyone want this up, or should I erase it?
You can erase it.
Okay. Goodbye. We'll revisit it if we have to. I love this board. It's like so nice. It erases so well. Like these boards, not so much. Okay, so we have a kidney problem. What are some diagnostics tests that we can do to figure out what kind of condition our kidney's in?
IVP. Isn't that what it's called?
I'm just thinking more like labs right now.
Oh, you and
Yeah, so there's bun, there's creatinine. What are some other tests we can do?
GFR.
GFR. What else?
B and creatinine ratio.
Yes. So
Potassium.
with specific gravity. So I put spec grav. Remember what specific gravity is?
It's the concentration.
Yeah, so it's like how yellow is your pee, right? It's super, super dark, super concentrated, super, water looking, is super dilute. And then you can always do a UA, right? A urinalysis. Okay, so pretending the kidney is damaging or is damaged, it's in distress. What do you expect to see with these things? Would bun go up or down?
Up.
Or creatinine?
Up.
GFR? Down. Specific gravity?
They could go up or down.
Yeah, so it depends, right? What kind of stage of, and that was kind of quick trick question, so good job. Specific gravity is, about the concentration again, and that kind of depends what stage of kidney disease we're at. Like when we get to acute kidney failure or acute kidney injury, we'll see that there's different phases. There's the acute phase, the Aldosterone phase, the diuretic phase. So it kind of depends. When it's high, when the concentration is high or low, other than kidney disease, what are some other things that can influence to make it high or low? High is concentrated, by the way. Concentrated, and low is dilute. So other than kidney failure, there are a couple other things to keep in mind. What could make something really concentrated?
Dehydration.
Exactly. So when you're dehydrated, you probably have noticed that your pee is darker. What about when it's low? Yeah, so when you drink a lot, fluid overload, also diabetes insipidus. That's where, you literally are just like peeing everything out. Because do you remember the hormone ADH, anti-diuretic hormone? It's a syndrome where you just like, that's all out of whack. So you're just literally going constantly because the ADH isn't working. Anyway, so those are just a couple things to keep in mind. UA, what are some abnormals for a UA?
Things like red blood cells.
Yeah, you don't want red blood cells. Call that hematuria. What else? Glucosuria. What else? Yeah, protein, which would be or the albuminuria. White blood cells. Yeah. What else is here? Ketones. And bilirubin, yeah. So we know, like if someone has a UTI, we expect to see like white blood cells and red blood cells. If someone's got like diabetes or whatever, we expect to see glucose and ketones. Protein is a big one. This is actually one of the very first signs that you'll notice when someone has early stage chronic kidney failure. Because what's happening is that slowly over time, your kidneys are getting damaged. I don't know if you remember like the anatomy of the kidney back from like A&P or not. It might help if I draw something to help you kind of visualize. Hopefully it'll look better than my lung did. So this is your kidney. These are the tubes that come out. So this is the ureter, right? the part that connects to, you know, the bladder and you pee out. This is called the renal pelvis. I don't know why it's called that. It just is. It's the part that receives all of the fluid that's going to get excreted. And then you have like these like little sac-like things inside. Who knows what those are called?
Oh, the glow.
The nephrons. Within the nephrons, you have the glomerulus. So if you were to like super zoom in, we'll go like this. Super zooming in, it looks like you've got your, this is going to be really hard to draw. Your glomerulus is basically like a bunch of capillaries, right? And that's where you get like the whole loop of Henle thing, the descending loop, the loop of Henle, and then the ascending loop, right? And then this is basically the filtration process. There's a bunch of capillaries, arteries, veins that like interchange, and they're like exchanging water, exchanging toxins, exchanging nutrients. And a lot of that's happening here. And then like eventually they like decide what they're going to keep through this loop, and whatever gets thrown out gets spit out of the nephron and down the ureter, and it gets peed out, right? So sorry, this is kind of all over the place. So where was I going with this? The protein, early sign of chronic kidney disease. Now what happens is in the glomerulus, it's very, very tiny, like microvascular capillaries, like very small. Like these veins here that you can see on your arms are very big. Inside the kidney, it's like very, very, very tiny. They're just very small, so they're very easily damaged because they're so small and vulnerable. So what happens is some risk factors for chronic kidney disease. Do you know any? What's the leading cause of chronic kidney disease? Diabetes and hypertension. Diabetes is number 1. Hypertension is number 2. Pretty much, I think it's something like 1/3 of people with diabetes end up getting chronic kidney disease. So don't get diabetes, is my words of wisdom for you. What happens with diabetes is that when you have constant state of elevated blood sugar, your kidney is what filters everything, right? All those toxins. So constantly having like a super high blood sugar is really irritating to the blood vessels, and that's why you get like the nerve damage in like the feet, because it's irritating to the nerves. It decreases sensation, and then you get like the diabetic foot ulcers, right? The same thing's happening like in the tiny glomerulus in your kidneys, because they're constantly filtering out the waste. They have to filter out glucose all day long, and so it's just slowly damaging. And so what happens is the tiny little vessels inside the glomerulus, they are getting weakened, they're getting hardened, they're getting more fragile, and so they stop being able to do their job really well. And that's when like they slowly start to leak protein, because whenever something's being damaged, it releases protein into the bloodstream. It's like when you have heart damage, you're releasing what? Starts with a T. Troponins, right? So troponins are specific to heart muscle. All right, if you damage, I don't know, you get in like some kind of compartment syndrome and damage your muscles really bad, you release myoglobin into the bloodstream. That's protein from your muscles, right? So the microalbuminuria that they mention all the time in the CKD is the protein that's being released from the damage from the glomerulus. Does that make sense? So this will be one of the first things that shows up, and they might not have any other symptoms. They might just have unexplained that's really hard to say, microalbumin in their pee, right? So that, I think that's probably going to be important to know, is like, what's the earliest sign? Unexplained microalbumin with no other cause, right? And it's specifically linked to damage from the glomerulus from either diabetes or hypertension. Now, hypertension, they both have the same result, damage to the glomerulus, but the diabetes is related to the elevated blood sugar. The hypertension is related to the fact that, you know, when you have your high blood pressure really high, it's damaging to arteries. Like whenever you have constant pressure, it's just damaging. Like if I kept stretching a rubber band over and over again and kept making it harder and harder, eventually it's going to either snap or lose its stretchy, right? So when your blood vessels are constantly like experiencing an increased pressure, they either like lose their ability to like be elastic, or they just get really weakened, and so they're not able to like regulate your blood pressure as well. And so all those changes are also being felt in the glomerulus, because again, your kidneys filter all of the fluid in your body. And every time your heart beats, I think it's something like 1/3 of everything your heart, with every beat, a third of it goes to the kidney first. So like your kidney is one of the first things to feel like high blood pressure. Does that make sense? So high blood pressure really starts to damage the glomerulus, and high blood sugar starts to really damage the glomerulus. So the first thing you'll see is the proteins from the damaged glomeruli. Does that make sense? Just want to make sure you understand that because I feel like it's probably a test question. Okay. Diagnostics. Any questions about these diagnostics? Go ahead and erase these. I wanted to, before I erase them real quick, I know when I was in school, I didn't really understand what is BUN creatinine. The BUN is a measure of a waste product that's produced by the liver. The liver is involved with, and you'll get into this next topic because you guys are doing liver next, right? The liver produces ammonia and nitrogen or whatever, and then your kidneys excrete it. So when your kidneys aren't able to excrete it, your bun level goes up, and then your creatinine is a waste product produced by your muscles. I don't know if you guys have heard guys who are trying to bulk up, they take creatine. It's similar to the creatinine, so it's specifically towards muscle protein. So you're constantly producing creatinine every day because you're constantly rebuilding muscle because you're regenerating all the time. You're constantly sloughing off skin cells and hair cells. So you create creatinine every day, but when it's elevated, it's because your kidneys aren't filtering it out. And so that's why guys who take a bunch of creatine supplements, they can start getting really bad kidney damage because it's artificially raising the creatinine super high, and your kidneys can't keep up with filtering it out. Does that make sense? That's why one of the issues with taking a bunch of creatine is kidney issues. Tell guys to take it easy on that. Getting strong isn't as important as not having kidney failure. Anyways, okay, I'm gonna erase this. I don't want that eraser. I want this eraser. Am I making sense or am I rambling?
It makes sense.
Okay, I'm trying to do big picture because sometimes I feel you can get so okay, polycystic, okay, nephrotic without seeing how it all ties together. And at least for me, that's helpful to see how everything works together. Okay. Don't be afraid to ask questions. Let's see. Do you want to do polycystic and glomerulonephritis, or do you want me to just go straight into AKI and CKD and then come back to those?
I think going straight to the
What do you guys think?
Okay. Those are bigger sections.
Yeah. Okay, so acute kidney injury isn't always from long diabetes or long hypertension. It can be from all sorts of other things that go on, but there's three, and there's so many different causes, right? They categorize a bunch of different causes into three potential options. You remember what they're called? Yeah, pre-renal, meaning before the kidney. Intra-renal, meaning the problem is within the kidney itself, and post-renal, meaning something's happening after the kidney. So there's just so many reasons why there could be an acute kidney injury. They make these three to make it more understandable. So if something's happening before the kidney, so let me just draw my stick figure man. He's my friend when I teach. Looks terrible, I know, but it's fine. Okay, so we'll have the heart here, and we'll have, these are kidneys, and we'll make this a bladder. I'm sorry, but you get it, right? You get it. And we'll make this the blood, the aorta going to the kidneys and then out. Does that make sense? Heart, arteries, kidneys, bladder, pee. Okay. Work with me. Okay, so pre-renal means it's happening somewhere up in here, right? Above the kidneys. What are some causes that could be affecting the pre-renal?
Hemorrhage.
Yeah, so anything that causes hypoperfusion, right? So the kidneys, like I said, are the first ones to sense there being a change in blood pressure because I think it's a third, correct me if I'm wrong, a third of every pump that your heart makes goes straight to the kidneys first. So they'd be the first ones to notice, hey, wait a minute, we're getting way less than usual or we're getting way more than usual. So anything that reduces perfusion And there are several things that can reduce perfusion, right? And you said, what did you say?
Hemorrhaging.
Hemorrhaging. So hemorrhaging, you're literally just bleeding out. That would, make your perfusion not so great. What else? Dehydration, definitely. This is also reducing amount of volume. Another one, which isn't necessarily related to perfusion, but hypoxia. So this is kind of related to the blood because, again, the red blood cells are the ones that deliver the oxygen. So if there's hypoxia, it would be logical for the kidneys to be like, oh, there's not enough blood flowing because there's not enough oxygen. So maybe there's not enough red blood cells. So in this case, if it's a perfusion or hypoxia issue, the kidneys are going to think, hey, the blood pressure is too low. What are we going to initiate? What did I draw over here last time in red?
Oh, the
ROS, right? So whenever there's reduced blood pressure due to hypoperfusion, hemorrhage, dehydration, hypoxia, the kidneys are like, oh, we must get perfusion back to normal, right? So they're like, let's kick in the ROS, right? And we increase the blood pressure by 2 ways. Remember what those were? What was the first one? Constriction. Constrict. I was like, how do you spell this first? Constriction. And what was the second one?
Aldosterone.
Yeah, so sodium, and which leads to increased water. So that's what the kidneys are going to do in response to this. Which, if the kidneys are like in distress, probably not the best for them. So a lot of the compensatory mechanisms that our body does often are not helpful. They're often actually very unhelpful. Okay, does this make sense? Are there any other ones that were in your notes besides these?
Third spacing.
Yeah, okay, so
Burns
third
and
spacing is kind of the same thing because the fluids are leaving what? They're leaving the vascular system and leaving and going into the body. So it's basically the same thing as hypovolemia or reduced perfusion because the fluid just isn't where it's supposed to be. It's now in your tissues, not being helpful instead of being in the blood where it needs to be. So I can add that here. Third spacing. Does this all make sense? So there might not even be anything wrong with the kidneys at all, right? Like if you just fix the perfusion and the volume problem, boom, everything's fixed, right? So it's not really anything wrong with the kidneys at all in the pre-renal. All right, what about intra-renal? Yeah, so remember I talked about the glomerulus, right? So any damage to the glomerulus itself would be intra. So we'll put, what is it, glomerulonephritis? Glomerulonephritis. Okay, so this could, eventually lead to like chronic if you don't fix it, right, over time. Because acute kidney injury is reversible if you fix the problem fast enough. If you don't fix the problem fast enough and it like does permanent damage, like to the glomerulus, you can't undo that. Like you can't magically put the glomerulus back together. Just like when you have a heart attack and you damage the heart, you can't fix that. Like your heart's permanently damaged and it's always going to be that way, right? So fixing the problem early. What are some other intrarenal things?
Nephrotoxins.
Yeah, so gosh, I cannot speak today. Huh?
Like nephrotoxins.
Yeah, nephrotoxic drugs. Do you guys need to know what they are, or is she just like
Enzymes.
Enzymes and the contrast.
Yes, IV contrast, the mycins.
I think mycins was stressed instead of
Was it?
well, yeah, actually all of them.
Yeah, I just didn't know if you had to know that or not. So again, that's directly damaging the kidney. What else? And then acute tubular nephrosis, ATN. That's, remember the little tubules I was drawing? When those get damaged, they're unable to like reabsorb fluids and all that stuff. So it's not the glomerulus that's having the issues, it's the tubules, but I mean, ultimately has the same result. So beautiful, I know. Okay, any questions about intra? No? Okay, and then post-renal. So the intra-renal was, in here, right? So pre, intra, and then post is going to be the bladder and down. So this is going to be our post section. What kind of things can we think of that would cause post problems? Kidney stones, good. Why would that cause a problem?
It obstructs the flow and it backs up.
Yeah, exactly. If the pee can't get out, it's gonna stay there and then slowly back up into the kidneys, and now they're gonna be like backed up and like explode. You know, not literally, but essentially. Kidney stones. What else can cause a problem?
Tumors.
Yeah. So why a tumor?
It's obstructing.
Same thing. If you have a tumor like right next to your ureter and it compresses it, guess what? It's not flowing out. You know. So I think there might be a few more things. What else in men?
Prostate.
Yeah. So a lot of older men. And what's an early kind of warning or like sign that a man might be starting to have issues with their prostate?
The break in the urine stream.
Yeah. So like, you know, like it's dribbling and they're like not able to like initiate and stop. It's just kind of like, it's not like a nice steady stream. It's just kind of like hard to start, kind of like choppy, and you know, and they're like straining to get it started, you know, all these things. To like overcome the resistance to get it through, they have to push harder. And so if a man has that, like he could be developing, you know, slowly over time, if it just is a chronic obstruction and he's not really like aware of or like doing anything about, it could slowly keep backing up and like damaging the kidneys. So that's another risk factor for chronic kidney disease, is a chronic obstruction. And I feel like a lot of the times it happens with older men with their prostates because it's kind of an embarrassing topic for them. They don't really like to talk about it, so they just kind of let it go and like, it's fine, I'll sleep it off. You know how guys can be sometimes. What else? I think that's it. Or okay, what if you're in the hospital and you know they don't have kidney stones, you know they have a tumor, it's not even a man, it's a woman, but they have a Foley. What could you be thinking about that?
Or something.
It'd be clogged.
Yeah, so the Foley can get blocked. You know, it's a tube, right? So especially if they have kind of like sediment in their urine and maybe have a UTI. A lot of older ladies have UTIs. It's notorious, right? Old men typically have prostate issues. Old women typically have UTIs. So there's a lot of sediment and cloudy stuff like in the, have you guys seen sedimenty urine where it's like literally pieces of sand? It could easily block off the tube in the Foley, and you're creating like an artificial, you know, obstruction. And, you know, that's important to know, so you're not giving your patient an AKI from a blocked Foley. So you can remove it, you know, try a different one and see if that fixes the problem. Any questions about any of this? It's pretty helpful. What can you do if you're not sure, you're exhibiting signs of an acute kidney injury, but you don't know if it's pre, intra, or post? What can you do to kind of rule out some things? What can you do to rule out if it's a pre-renal issue?
See if fluids fix it.
Exactly, a fluid challenge. Because remember the pre-renal issue was that it has you know, hypovolemia and decreased perfusion. So it's a lack of volume issue. So if you give them a fluid bolus and all of a sudden it's fixed, they start peeing again, great, awesome, acute kidney injury fixed. Now, if you give them the fluid challenge, I forget exactly like what the exact numbers were. I don't know if you have to know that or not. Do you have it in your notes? Is it
We
something
don't
like
have a kidney challenge or anything. So.
You don't have a fluid challenge in there? I saw it on the.
It says we have to have like a urine output of 100 to 400 milliliters a day, but that's the only number that we really have.
Okay, I guess you don't have to know. So the fluid challenge, yeah, if it fixes it, you know that it was a pre-renal problem, like maybe they were just massively dehydrated or they had really low blood pressure for whatever reason. You give them fluids, now suddenly their kidneys are back up and functioning again. Great, fix the problem. Now, if you give them the fluids and nothing's happening, you can rule out pre-renal as a cause, and now look at these two. And I feel like post-renal is pretty easy to figure out too. Are they a man or a woman? If they're a woman, there's no prostate issue. You know, a quick scan would tell you if they have a tumor. You know, same thing with kidney stones. So if there's nothing there, then it's got to be intra, right? And you can check their pee and look for, oopsies, what are you going to check for in their pee to see if there's damage to the glomerulus? What does it?
Albumin.
Yeah, the albumin. Remember the proteins that are, whenever there's damage to something internally, it'll show up in some kind of protein. the troponins are the heart, myoglobin are like the skeletal muscles, and the albumin is from, you know, things like the glomerulus. So that's why we check troponins for NIs. Does that make sense? So that's how you can rule out what's going on with them. Now the phases of the acute kidney injury, and I kind of got into that a little bit about like, oh, are they peeing or not? So the first phase that you realize, okay, my kidney's in trouble is, what's the first phase? Oliguric, which means what? Yeah, right. So suddenly you're just like not peeing, right? And that would, you know, make sense with these, right? Like, if you have really low volume or you're massively dehydrated, your body's going to initiate the ROS, right? And also the aldosterone, right? Which makes you want to reabsorb the sodium. So you're going to reabsorb the water. And then there's also antidiuretic hormone that will get released. And antidiuretic means the opposite of diuretic, which means to pee. So it's to not pee, right? So your urine output is massively decreased in an attempt to increase your volume. Does that make sense? So the volume is a problem, so they're trying to retain it. And that's why the fluid challenge works if that's the issue. All right, so what about the second phase? Yeah, diuretic phase. Now, is this good or bad?
I mean, so the kidneys are beginning to.
Yeah, so this is good news. It's like, okay, awesome. The kidney is in the healing process, right? In the first case, I guess in the first case, the oliguric phase, there, in addition to the volume, it's not able to filter. What do you expect the lab values to look like? What's bun and creatinine going to look like? What about weight gain? Increase because you're retaining, right? What about blood pressure?
Increase.
It's gonna, yeah, through the ROS system, it's gonna increase, right? Because the problem is that it was low, right? So it's gonna try and raise it. What about edema? Yeah. Okay, so now when your kidneys start healing, either by the fact that you gave them a fluid bolus or that you stopped giving them nephrotoxic drugs, or you removed the obstruction, your kidneys will start to heal and be like, okay, we can pee now, right? So they'll start massively diuresing to kind of get rid of, you know, the issues of like the edema and all those things. So it's a good sign. The reason why it's going to be so much is to try and get rid of that. Is the urine going to be concentrated or dilute? Dilute. Right, and this is because while it's still recovering, it's still unable to like specifically concentrate the urine, but this is still heading in a good direction. And then the third phase is just good. Yeah, we're recovered. So awesome. Now, this will help you when you go to look at chronic kidney disease, because it's literally the opposite order, right? Because again, oliguric was the problem, and like the diuretic was the healing phase, so getting better. So in early stages of kidney disease, which one is it going to be? Diuretic is going to be early, because this is when it was bad and getting better, right? So an early stage it hasn't gotten quite bad yet. So early stage is diuretic, and as it gets worse, it goes to oliguric. Does that make sense? It's literally like the opposite, which confused me for a long time. I was like, wait, how is the order opposite? But then I realized like, oh, well, like as it gets better, it gets diuretic, right? So like when you have chronic kidney disease, it's not quite as bad yet. So when it's like less bad, it's diuretic. When it gets really bad, then it's oliguric. Does that make sense? Hopefully that helps explain a little bit. So like early stages, diuretic, late stages, oliguric, or you're just not able to produce at all. And this is when you're like in the acute bad phase. So does that make sense? Because that confused me for a long time. I was like, wait, that doesn't make any sense. Okay. Can I erase this, or does anyone want to take a picture of it? I don't know if you can see it from over there. You got it? Okay, I'm going to erase this guy. Any questions about acute before we go to chronic? No? Clear as mud? Is it just making so much sense, or you just guys overwhelmed and brain dead? Both? Okay. Sometimes when students like are just quiet and looking at me, I'm like, did I just answer every question you have in your entire brain, or are you just like so overwhelmed?
Well, can I ask, like, with potassium, with this, how are those levels shifting?
Yeah, so acute kidney injury is going to be similar to chronic, but just chronic is going to have a lot more symptoms than acute, because usually acute kidney injury happens pretty quick and is resolved fairly quick, right? So like you don't have a ton of time to develop all these other symptoms, if that makes sense. So like you're not going to typically have like a bunch of the symptoms that chronic kidney disease has, just because acute kidney injury doesn't last as long. That's why it's acute instead of chronic. So like you can see some of the same stuff, but you might not see all of it, because like a lot of these symptoms take a while to like manifest.
I was getting, like, for all uric, according to like the book in which she has in a class, like when your sodium increases, your potassium increases, but typically it's like the sodium potassium pump.
Yeah, I don't know about that specific. You'll have to
Okay.
specifically ask her.
Yeah, she said they're both elevated. I don't know if it's just because the potassium is not being excreted, so it stays elevated.
Well, if you go into acidosis with acute kidney injury, I mean, I guess you could. I guess it depends on like how quickly you fix it. We're going to talk about acidosis here in a second and what that does to potassium and stuff. So, do you want me to go into that first and then chronic, or go chronic and then acidosis? I know acidosis like isn't technically a section, but it will really help like explain everything.
Yeah. I could do the acidosis and the chronic.
So I think you walked in when I was talking about this, but in acidosis, your kidneys help a lot with the acid base balance, right? And there's hydrogen in your body which is acidic, and there's bicarb. Bicarb is the base, right? Your kidneys are responsible for producing and reabsorbing bicarb to keep the balance level, right? So the hydrogen is just there. And then your kidneys are like, okay, should we excrete some bicarb to keep it in balance, or do we need to absorb more? But they're no longer able to because they're damaged and broken. So if your bicarb goes down, right, that's going to automatically make you start being acidic, right? So that puts you into acidosis. And a lot of the stuff that we're going to talk about with like chronic kidney disease is going to look a lot like diabetic ketoacidosis, because again, diabetes is the main cause of kidney disease, and like you can get acidosis from both of those, from diabetes and like chronic kidney disease. So in acidosis, and I don't remember if you remember it, I don't know if you remember any of this stuff, but when you're in acidosis, you have electrolytes inside your bloodstream, right? This is a vessel, okay? So bloodstream, you've got sodium, you've got potassium, you've got blood cells, whatever, chilling. And then here's your cells, right? Your tissues that are getting perfused with the little capillaries and stuff. So in acidosis, the pH shift causes, most of the time, potassium is stored inside the cell. I don't know if you know that from A&P, that was a while ago, but this is where most of the potassium chills and like lives by default. So during acidosis, I don't remember exactly why. I tried to look it up before I got here. The reason specifically, like the pathophysiology behind it, I don't remember. But during acidosis, the potassium leaves the cell and goes back into the bloodstream. Okay, and I don't remember exactly why. I don't know if that would help you anyways. But now suddenly all this potassium is going into the bloodstream, right? So now you have hyperkalemia, which is one of the symptoms you saw in chronic kidney disease, and it's specifically related to the bicarb situation. Now you see this a lot in the diabetic ketoacidosis too. They have the hyperkalemia. Now, what do you do to treat this? If someone's got hyperkalemia, it's like, oh no, what do we do? You could give them bicarb. They have that in like the code cart or the crash cart. There's specifically a drug.
Oh, is it the
Yeah, K-exolate. Now, K-exolate, I like that name because it literally just like does exactly what it says. Like X is like get rid of, and K, so you get rid of K. Beautiful. The problem with this is that we want the potassium to be in the cells, right? That's where they belong. That's where they're supposed to be. But since everything's out of whack and out of balance, the K moved from the cells and went into the bloodstream, which is bad, right? And so we know that hyperkalemia was a symptom. What was symptom with sodium? what happened to sodium?
Hypertension.
I mean, is it gonna be high or low?
Oh, high.
Low, right? Hyponatremia. Because the sodium and potassium are always inverse.
And that's why I was confused because
Right.
in oliguria, it was saying that we do have an increase in sodium, but also an increase in potassium.
You'll have to ask her specifically because I don't know. There was another issue that came up in last ASAP that was similar to this, and then one of the students just texted her or emailed her, and then she answered and clarified. So I would just do that. I know that the K and the sodium are inverse, so when one's high, the other one's low. And hyponatremia is a symptom of CKD, and the hyperkalemia is a symptom of CKD. So the issue is if we give K-exalate, like the K-exalate makes all of the K go away, right? So now you have all the potassium in the bloodstream is now gotten rid of. So now you don't have potassium anywhere, right? It's not in the cells, it's not in the bloodstream, which is not a great situation, right? Because your body needs potassium, for heart rhythms and different things. So instead of giving just K-exalate, what they say to do is, and it sounds funny because none of this has to do with blood sugar, but they say to give insulin. Yeah, so what insulin does is it pushes the potassium back into the cell. It helps to reverse that acidosis thing, which is, often why we see like in the diabetic ketoacidosis, they're resistant to insulin, and so it's not doing its thing. So the tons of potassium issues. So it'll put the potassium back into the cells. But if you give someone that's not a diabetic a ton of insulin, what's going to be a problem? Their blood sugar is going to super drop. And it's like, oh, that fixed one problem and caused another problem. So what do you have to give with it? Insulin. All right, you give them some glucose to go with it. So insulin plus glucose. So do you see why this is better than the K-exalate? Because you need potassium, you can just get rid of it, right? Like, if you had enough potassium to go around, sure, but like it's better to do this too. What was your original question? You asked about, was it the issue with the sodium thing? Yeah. Does this help explain anything though? Like why the potassium levels are high during the CKD because of the acid base and the bicarb situation?
Yeah, that makes sense.
Okay. Where did it say, what specifically does it say about the thing in your note?
Under like the oliguria, it just says,
For the acute kidney?
yeah,
Okay,
it
what
just says sodium, potassium, and then in class she said they're both elevated.
I guess here's what it could be. It could be hypernatremia during the oliguric phase if the cause was a pre-renal cause where you had a volume or blood pressure issue, because then the ROS system is going to make you reabsorb the sodium, right? In order to because remember you're trying to reabsorb sodium in order to raise the blood pressure. So I guess that could be it if it was that cause, but I don't know. You have to specifically ask her. Does that make sense? Yeah. I don't know, because my notes say the opposite. They said because you're reabsorbing too much water, it dilutes the sodium. So I would just send her a specific email about that particular question.
That's what we've been taught from the start, is that they're all kind of opposite of each other.
So I would just make sure maybe it was a typo or something. Make sure she didn't have a typo, because that can sometimes happen.
Except where the book says high sodium.
Yeah, see that I just asked her. Just ask her. It would make sense if it was the reason that I mentioned. So, anyways, we'll take a break from that to not confuse you further, and we'll go to what was it? Chronic. So we'll do chronic now. All right. What was one of the early signs and symptoms?
Microalbumin.
Right, microalbumin in the urine, and that results from the damaged what? Glomerulus. And what are the two leading factors of this?
Diabetes.
Diabetes is number one, and what's number two?
Hypertension.
Hypertension. Boom. A+ on the test. You guys are ready. Okay, now with urine output, what's it going to look like in the early phase? Diuretic, right? opposite of the stages of acute, and late oliguric. Okay, we'll leave that there. We talked about azotemia, we talked about uremia, talked about uremic halitosis. Another sign and symptom is hypertension, and this is related to the the water and sodium reabsorption, right? Not able to filter the out. Now pericarditis is also a sign and symptom or of CKD. Can you think maybe why that would be?
Because of like so much of the toxins.
Yeah. Yeah, so pericarditis ends in itis, which is inflammation, and usually inflammation is caused by irritation. So if you got all these toxins floating around, and your heart and the kidneys are the two places that like touch all of the blood in your body all the time, right? It's like a constant loop. Heart, kidneys, heart, kidneys. So if there's a bunch of toxins in there, your heart's going to get damaged. Pericarditis. What other heart complication can you get related to fluid overload? Yeah, CHF. I was thinking of something else, but that works too. So
This is the pericardial friction rub?
question mark. Cardiac tamponade. But yes, also the friction rub. And I'll explain here in a second. Cardiac tamponade. I remember tamponade because it has the word tampon in there, which has to do with like fluid. So that's how I remember that. Sorry to the men watching. Yeah, so cardiac tamponade, your just fluid starts to like, surround the heart, which puts stress on it because now it's like pressure, like fluid causes pressure, right? So you got this fluid surrounding the heart causing it to stress. A fluid overload, we know, can lead to heart failure because it's not able to pump and meet the demands. What was the one that you said?
The pericardial friction rub.
Right, the friction rub. So you'll often hear that with tamponade, like as a heart sound, because like the heart is like in distress, and so like I think we talked. No, you weren't here. No, somebody else. It's what you're hearing is like the layers like kind of rub against each other because it's like kind of getting inflamed because of all the issues. You'll hear it with pericarditis as well. Like the layers, like the end. What is it called? The epicardium, the endocardium, the different layers like are inflamed and like rubbing. There's supposed to be like a fluid layer between them, so it like so it reduces friction and makes it more like kind of smooth rubbing against each other, but you can't when it's inflamed. So you hear the of the layers, and it sounds really sounds like. Have you guys ever ridden horses? It sounds like the sound that saddles make, like the leathery, like, and it's very discomforting. I don't appreciate that sound. Yeah, so pericarditis, cardiac tamponade, the friction rub for sure. You hear that, all related to fluid, right? Fluid overload that causes all of them, except for those toxins with the pericarditis. What are some other signs and symptoms you would see? The pericarditis here. Pericarditis. Friction rub.
The uremic symptoms.
Yeah. So the ones I kind of mentioned earlier, uremic frost and the halitosis. These are all related to the toxins. What kind of signs, and mentioned it early in the beginning, would be related to if the body's not able to produce the erythropoietin?
Can eventually lead to hypocalcemia.
Huh?
The hypocalcemia.
The erythropoietin.
That's
That's the red blood cells.
like anemia symptoms.
Exactly. So the erythropoietin is a hormone that produces the erythrocytes, which are the red blood cells. It's just,
She had just kind of looped that all up together for us, like the erythropoietin.
yeah, I'm trying to break it down as best as possible. So your H and H will be smaller because your red blood cells are smaller. So you're going to have very similar signs and symptoms to anemia, which are, fatigue, shortness of breath because of the oxygen, lethargy, dizziness, that sort of stuff. Smalls, which we mentioned already, related to acid base, and hyperkalemia, which we mentioned related to acid base. Were there any other signs and symptoms that you guys have that I didn't mention?
Low iron and folic acid.
Yeah, that's related to the,
H.
yeah, so that all ties in together.
She did say hypocalcemia.
Yeah, so I talked about the calcium. Oh, you weren't here in the beginning. So yeah, so electrolyte imbalances, and we'll talk about the vitamin D, right? So the kidneys produce the vitamin D. So your vitamin D will be low, right? Because it's not that. What is that? Your kidneys can't produce it, so your vitamin D is going to be low. And vitamin D helps you to absorb what? Calcium. You can't absorb calcium without vitamin D. So like when you go to the store, pretty much everyone in America has a vitamin D deficiency and they don't realize it because we sit inside most of the day. We don't go outside like we used to. No one farms like they used to. Right? So people generally have vitamin D deficiency, but people are taking calcium supplements all the time. But it's not really helpful unless you have like sufficient vitamin D. So usually doctors will like give both together, a vitamin D and a calcium, because you need both, right? And just like sodium and potassium, which are inversely related, calcium is inversely related to what? You mentioned at the beginning.
Phosphorus.
Phosphorus, right? So we'll just put phos. So when calcium is high, phosphorus will be low. When calcium is low, phosphorus will be high. So no vitamin D, can't absorb calcium. Calcium is going to be what? High or low?
Low.
Low, which means the phosphorus is going to be high, right? And there, I looked up signs and symptoms of like hyperphosphatemia, and there really aren't. What you see is the signs and symptoms of hypocalcemia. So what are some signs and symptoms of hypocalcemia? Do you remember?
Something you like, the Trousseau or the
Yeah, those weird names, the Trousseau and the Chibosticks. How to say that? I don't remember which one is which, but it's like the
So
arm and
the
the curling.
Trousseau is this type
The
thing. and
curling
the
with the blood
cheek
pressure.
is the Chibostic.
Yeah. What was it with the cheek again?
You tap and it like. and
You
it
tap it, makes
triggers
your-
it or something or hyper.
I wonder if I have hypocalcemia, because I don't know, or maybe it's a nerve thing, because like if I tap a certain spot, like I feel like a nerve thing, but I don't know if that's related. It's fine. I'm fine. It's all fine. Probably just related to vitamin D levels. I need to be outside. Anyways, yeah, so you can kind of, when you know the functions of the kidney, which we talked about in the beginning, that it does acid base, that it regulates fluid, erythropoietin, vitamin D, fluid balance, you can kind of already like know what the signs and symptoms are going to look like when you just imagine the problems with the functions, right? So like most of these signs and symptoms are related to the functions, right? So it produces vitamin D, it can't, so the phosphorus is high, right? Does that make sense? If you really know the functions really well and like what the kidney does, it'll be very easy to think backwards, like, okay, if it's not doing that, what's the problem? Does that make sense? So it might seem like easy to skip over that part, but if you know that really well and you can just list off the functions and like kind of what I did in the beginning, like signs and symptoms will be like super easy. You'd be like, oh yeah, well, it's just the opposite of what it's supposed to do. Does that make sense? Okay, so if someone's got CKD, what are some treatments? So again, treatments are just going to go directly to the signs and symptoms, which are directly treating what the functions are. So we just got to work backwards. We look at the problems, we treat them. So what would we do to monitor their fluid problems? Yeah, so daily weight is super important. Treatments here. So daily weight, this will tell you if their fluid balance is recovering, getting better, or if it's getting worse. If they keep getting heavier, what does that mean? Retaining fluid and probably getting more third spacing and edema, which is the opposite of helpful. If the fluid went back into the bloodstream, it could get peed out and that would fix it. Okay, what can we, what else? What else can we do as nurses to help with their fluid?
Eyes and nose.
Yeah,
Well,
very
that's
strict eyes and O's, right? So a lot of the times in the hospital, especially if the patient is like a walkie-talkie, which is means they're fine. Or they're up ad lib and they're like, living their best life. We don't really typically do strict eyes and O's. They're like, oh, they peed today, they're good. Like we don't like calculate everything like super like that much, because if they don't have any issues with that, you typically don't like get super strict, right? Like for clinical paperwork, obviously you want to practice doing good eyes and O's because it's a good practice to have, but you'll start to realize which patients it matters more for. Someone with any kidney issue, eyes and nose matters a lot. So like it's way more important to focus on like focus assessment. So if someone's there with a lung issue, you care more about lung sounds, that sort of thing. Does that make sense? You kind of focus on what the issue is. Anyway, so strict eyes and nose, and like maybe they have a fluid restriction, right? Maybe they only get to drink, half a water bottle a day or whatever it is that the doctor says, right? And patients hate that. They're like, I'm thirsty or whatever. It's like, well, you're already fluid overloaded and we can't give you any more. So a lot of times they'll give them like ice chips or give them those like mouth swabs because the mouth feels dry, you know, from not having fluid all day. So H2O restriction is another thing we do. And they'll put a big sign on the door letting you know that. How can we know that volume is an issue. Let's say it's a hypovolemic problem. How can we increase the cardiac output? What medications can we do to increase the cardiac output?
I know that one's for like vasodilation.
Yeah. There's certain blood pressure medicines, I should say. Which one do you say? Yeah, so ACE inhibitors, right? And that does what? We talked about the ROS, right? The ACE inhibitors inhibit the ACE enzyme in the lungs, which converts angiotensin 1 to angiotensin 2. So if the ACE inhibitor is inhibiting, then you never get angiotensin 2. So your blood pressure goes down, right? So increasing cardiac output, you give them ACE inhibitors. What are some other ones you want to give?
The beta blocker.
Beta blockers. Beta blockers literally do like the opposite of epinephrine. You know, epinephrine like increases like that fight or flight thing. It literally does the opposite. It blocks it, right? So it's going to decrease all the things, decrease your heart rate, also that kind of stuff. Kind of gives your heart kind of a rest. The ones that end in sartan, those do the vasodilation, which do the exact opposite of the angiotensin 2. So it acts directly on, I think they're called alpha something, the alpha agonists, or I think so.
Isn't it ARBs?
Yeah, alpha, I'm trying to remember what the ARB stands for. Alpha
Something receptor.
Oh, alpha receptor blocker. There it is. We got this. Alpha receptor blocker. I remember this one because sartan kind of sounds like soften to me, if that makes sense. And when something is more soft, it's dilated, and when it's like constricted, it's harder. So just kind of things to help you remember, tamponade, soften. It helps me remember vasodilation. So that's going to reduce the blood pressure, give the kidneys a break, because the kidneys think that they need to increase the perfusion to themselves. And what they do is end up hurting themselves worse by increasing the blood pressure and making the pressure worse. And especially if the CKD is caused originally from hypertension, and now they're making the hypertension worse. It's like a self-perpetuating cycle, and that's bad. So we give them these things to treat that so it doesn't get worse. How would we treat the problem with the lack of erythropoietin? There's a medicine I think called Epigen or something Procrit. Yeah, so different medications to help produce red blood cell production. Also, you can give them iron, things like that. The one that starts with B12 and folic acid to help with all of that too. How would we treat hyperkalemia? Talked about this already, but I'm see if you remember.
With insulin and D5.
Yeah, insulin, glucose, sometimes KX late, depending on the situation.
Albuterol. Albuterol is one that she mentioned.
For the potassium? What is that? That's for the lungs. Did it say that?
Wait, where did she mention that? It's with insulin drip.
Albuterol, like a breathing
No.
treatment?
Yep.
Interesting.
It says that it pushes the potassium into the cell.
Albuterol does?
Yeah, she says that it pulls the potassium back into the cells.
Well, that's something new that I learned today. Did not know that. The only problem I can foresee with that is that it can increase your heart rate, right? Which goes exact opposite to what a beta blocker is doing. So I guess it just kind of depends on what's happening with you. The doctor decides what to give you. The beta blockers reduce your heart rate. It's the opposite, because adrenaline increases your heart rate when you're scared. Your heart rate starts pounding. Beta blockers help reduce your heart rate, and albuterol can raise your heart rate. So if you're like giving them a beta blocker and albuterol, it's like, well,
Is it because like albuterol also has a chance of like raising your blood sugar?
No, that was beta blockers, wasn't it? It masks symptoms of hypoglycemia, whatever it was.
Yes. Yeah, I think it's some kind of like steroid drugs and
Yeah.
so
Yeah, steroids can raise your blood sugar.
Oh, albuterol, is that on steroid?
No, albuterol is that breathing treatment, you know, I
Right,
just never knew
nebulous.
that it had anything to do with potassium. That's something new that I learned from today, so interesting. Did not know that. Can neither confirm nor deny that statement. Yeah, I mean, that's pretty much, I mean, what else do you guys have? That's pretty much it for treatments. I mean, other than like dialysis, which you get when you're pretty much like in end stage renal disease.
She had said to eat low protein and real meat is better than like our fake meat, you know, for protein.
Yeah, well, everything's better than that.
But shoot, like the good protein.
Yeah.
When you're eating that low protein diet.
Any other treatments I missed? So again, it's really helpful to go back to the beginning and look at the functions, really know those functions, because then you automatically know the signs and symptoms, right? And then you automatically know what you got to do to treat it. You just pick each sign and symptom and be like, okay, how do you treat this particular sign and symptom? So half of it is done for you in your brain if you really know the functions really well, that we talked about at the very beginning.
She had mentioned calcium channel blockers to improve
Oh,
your
yeah.
GFR.
Yeah. Oh yeah, I had that written down, I just skipped it. Yeah, for some reason, those are really kidney protective. They just help for some reason, so that's also a really good one to add. Calcium channel blockers, or ACE inhibitor, or beta blocker. So I forgot anything else on here.
Did she say to have low protein diet, but like just make it plant, or was it high protein?
It was low protein, but to eat the high biological, which is like the real
So
meat.
you eat more if you're having a low protein, but
And
you wanna
not
eat more
beans.
meat than plant.
Yeah.
I was like confused because the point was just said eat high biologic protein. So like,
Can I erase this, or do you want to take a picture? You got it. Okay. I'm trying to think if there's anything else that I did mention. Did I talk about ADH? So ADH, you know, is the one that's the anti-diuretic hormone, right? So that holds your pee in.
So that's with like the high.
Yeah, so it's released by the pituitary gland, the posterior pituitary gland. You know, in your brain, you have your pituitary gland. And so pituitary releases ADH, and ADH gets released in response to two things. You have baroreceptors and osmoreceptors, and these are like, what is that? Baroreceptors, you ever heard of like barometric pressure? So it's like pressure. So this is like response to like what your blood pressure is, like how much fluid. And then they're like the osmolality of the urine. So it's like how concentrated it is. So like the level of like toxins and stuff in your bloodstream. So your pituitary gland is kind of like monitoring your vessels at all times for pressure and toxin level, and releasing ADH when necessary. So if your blood pressure is super low, right, your baroreceptors are like, alert, alert, we have low blood pressure. Would they release, or what's going to happen with the ADH? Is it going to increase or decrease?
You said this.
Your blood pressure is low. What happens? Right, because diuretic means get it all out, and anti-diuretic is the opposite of that, so hold it all in. So ADH holds pee in, right? And when you hold the pee in, you're essentially keeping it in your bloodstream, right? So that's going to help to raise the blood pressure, right? So in response to low blood pressure, you release ADH. Now, with let's say you have high levels of toxins like filtrates and waste products in your bloodstream, is ADH going to be increased or decreased? Oh boy. What do you want to do when you have a bunch of toxins?
I don't know.
You want to dilute them too, right? So in order to get rid of them, you have to have enough water to do that. So you're going to want extra water in your bloodstream to, number one, dilute them, and to give your body enough fluid so that they can pee it out. So ADH is going to increase, right? Because then it's going to bring the water back into the bloodstream to get dilute those toxins. Does that make sense? So when you have low blood pressure or high toxins, this is what's going to stimulate ADH to be released. Does that make sense? To hold that pee in, keep that fluid inside of your bloodstream. Because let's say you have, like, let's say you're really dehydrated and you haven't drank anything all day, and you have like a lot of waste products and toxins in your blood. This puts your kidneys in a bad situation because your kidneys are like, okay, we have all these toxins to get rid of, but we also don't have a lot of fluid either. So we get rid of the toxins by peeing, but if we pee, then we're going to also lose the fluid. So, you know, it's kind of like you're kind of put in a hard situation, right? So this is why your body like really concentrates urine when you're dehydrated, right? Because you don't have enough fluid that's dispensable, right? They're trying to hold on to as much fluid as possible because you don't have very much. So let me draw a little picture here. Let's say this is a glass, like a cup. And let's say this is the water level. Okay, let's say this is a full cup of water. So you're good. You have plenty of water. You have plenty of water. And you know, you have some toxins, right? This would be like dilute, right? So your pee would be pretty clear because your pee is the fluid is diluting the toxins pretty well. So your body, when you pee, it's going to look pretty clear because it's like, oh, well, we can get rid of plenty of fluid to get rid of these toxins because we already have plenty of fluid, right? Now, let's say you're really dehydrated and like you don't have that much fluid, and you might have the same amount of toxins, but it might just feel like more because the ratio, right? So your body's like, okay, well, we don't have a lot of fluid to work with, so let's try and get rid of the least amount of fluid as possible to get rid of these toxins. And you know how like there's a, like you can only dissolve so much in a certain amount of fluid. You know, like you can't just keep adding sugar indefinitely to like water because at some point it'll be saturated and you can no longer dissolve salt or sugar in some water because it's reached the point where it's like already saturated, you know what I'm talking about? So like the more fluid you have, the more sugar and salt or toxins you can put in because it can handle more. Whereas you can have like very little amount of water, you only put a little bit because it won't hold it, right? It won't be fluid anymore. It'll just turn into like a pile of like salt eventually. So that's why your pee looks super concentrated when you're dehydrated because your body's trying to conserve as much water as possible. So it's like, okay, we'll get rid of as many toxins as we can with the least amount of fluid as possible. So that's why it comes out looking super like amber colored. Does that make sense? So that's what the ADH helps do. It looks at the situation like, okay, what's our ratio of toxins to fluid and like, what are we going to do about it? Like, are we going to make it concentrated? Are we going to make it dilute? Can we afford to lose this water? Or do we need to hold on to it? Because your body literally needs fluids and water in your bloodstream or else you die. So there's that. You know, they're like, okay, they have to balance like, okay, perfusion or like encephalopathy, confusion, and like toxic death. Like it's a constant balance. So drink water is the moral of the story. Drink water and don't get diabetes. You'll be good. Did this make sense, this little picture? Yeah. I guess we can, let's see what time it is. Okay, do you want to briefly talk about some of the other ones like polycystic and things like that? Other than polycystic and like glomerulonephritis, which we kind of talked about throughout, and the diabetic neuropathy and the nephrotic syndrome, was there anything else in your notes that we didn't get? Oh, and I guess dialysis. We didn't talk about that really. Talk about that briefly.
I mean, she doesn't really hit dialysis until like the renal failure treatment lecture, so.
There was like one that was really short that's like 5 pages of notes with all the treatments for renal failure.
Oh. It's really
so like CRRT, dialysis,
yeah,
transplants.
Yeah. I mean there's a lot of like notes on it, but I don't feel like it's complicated. That's why I didn't like focus on it.
I'd rather focus on the actual disease.
Yeah, it's like, okay, like you get hemodialysis where they take it out of your blood, or you get like the peritoneal and it goes to the So it's like a lot, but it's not hard, if that makes sense. So I didn't focus on that. But I mean, if you have a question.
There's only a couple questions on that lecture.
Yeah, she did just post the
I haven't even
Study
actually saw
guide.
the study guide that she posted.
she just now posted it like 30 minutes ago.
Okay. Yeah, so if you have a specific question about it, I can, but I just kind of didn't mention it that much because I didn't feel like it was that complicated. Like I felt like this stuff was way more complicated. Okay, so polycystic, this one's not super hard either. That's why I kind of leave it for last. And on an easy note, polycystic is a genetic problem, right? So this isn't something related to like poor lifestyle or anything that's your fault. There's two types. There's dominant and what's the other one?
Recessive.
Dominant and recessive, good. So dominant requires how many parents that carry the gene? One parent. Recessive requires two parents. What's the percent likelihood that you'll get polycystic kidney if you have a parent with 50%? Good. 50% likelihood. Which one's worse to get?
Recessive.
Recessive is worse. I like to think that you have double the problems just because it takes two. So the reason why it's worse is you start developing symptoms when?
And the womb or right at birth.
Yeah, so you can develop symptoms in the womb, which is kind of hard to treat because you're literally inside some other person. So kind of a problem. So really early symptoms, right? Whereas the dominant one, you can maybe not have anything wrong with you until like even age 30, right? And then you start developing symptoms. So
They're like you die young with the recessive.
I mean, probably because you develop symptoms so early, you know, and it's probably hard to treat while they're in utero. So like constant kidney issues can lead to the chronic kidney disease even as an infant, you know, so that's kind of sucky. Okay, so what kind of symptoms would you expect to see? You have all these cysts in you, so it's probably gonna hurt. So pain, yeah, pain. Where? Abdomen and flank. Okay. What's your blood pressure gonna look like? Increased blood pressure. Pretty much whenever something is wrong with the kidney, you're gonna have increased blood pressure. And also it could be blocked. Those little cysts could be like tumors blocking some of the arteries. And then your kidneys think, oh, I have poor perfusion. I'm not getting enough blood flow. So what am I gonna do? The ROS, right, which increases your blood pressure because they think, oh, we got to increase the perfusion, right? They're not realizing that's just because there's a big old cyst blocking some of those arteries. Did you have a question?
I think she said that like the hypertension is usually your first sign that it's something wrong with them.
First sign.
Because if it's like unexplained hypertension,
Yeah.
that's when they start looking at kidneys.
Yeah, kidneys and heart are the first things you look at really to figure out what's going on. Is it a heart origin or is it a kidney origin? It's usually one of the two. Okay, what might you see in a UA? Yeah, hematuria, and you can probably imagine like with all these cysts and stuff, some of them probably are rupturing and they're just the blood's getting into the urine.
So like bacteria.
Mhm. Yeah, you get UTIs just because infection and all that. That's pretty much it for polycystic. So not super hard, right? Pretty easy. Erase this one.
She also said that the cyst could grow everywhere. Is that just because like?
I don't know.
That's why we could have antibiotics.
I don't know. I guess it might be just part of the gene that they can just spread around. I'm not super like familiar. I've never actually had anyone with this in my life.
Because it can cause aneurysm, she was saying, because
Yeah.
it can grow in the brain.
Yeah, so I guess they can start in the kidney and then just kind of spread and then aneurysm. I don't know, it seems kind of random to me, but definitely not nearly as complicated as chronic kidney disease. So, all right, and then the glomerulonephritis we talked about earlier, but we'll touch on it again. So you have those capillaries, right, that do the filtering. They're super small, super fragile, prone to damage. You can have acute issues. This would be related to like someone has an infection, specifically which types of infections. Strep. Pretty much everything is related to strep. So remember like endocarditis was strep, and the rheumatic, what was it? Yeah, the rheumatic is related to strep. So strep is just bad. Another one could be fluid overload, you know, damaging the glomerulus.
She mentioned lupus a couple times. Like, it's not a couple times in the notes, but like she specifically said lupus 2 or 3 times.
Yeah, lupus is an autoimmune, and the thing with autoimmune people with autoimmune problems is that you're constantly having like as if you're sick all the time because you're constantly attacking. So you get these antibody complexes. Yeah, so like you have whatever bacteria or invader you have right here with its little binding receptors, and you have your antibodies, right, that float around and then they attach, right? So then they start like attaching and creating these big old like complexes that just start clogging up the way, so they get stuck in the glomerulus and damage it. So any type of like autoimmune, and lupus is just a big one because it's systemic, right? Systemic lupus erythematosus, SLE, right? So you just have constant inflammation all the time. Because like I said, the glomerulus is really, really tiny. So these antibody complexes just clog it up. It's like a strainer, like when you strain things, like the big things stay, but the small stuff passes through, and it's just like get clogged with all this stuff with junk in them up. And then they're not able to filter like they're supposed to. So again, glomerulonephritis, you're gonna have decreased urine output. You're gonna have, stuff like white blood cells, blood, protein show up in the urine, reduced GFR, and again, you could be having glomerular issues from high blood sugar or hypertension. So glomerulonephritis was an example of the intra-renal issues that you could have with an acute kidney injury. I don't think there's much else on that one. I don't think. Did I miss anything? Oh, how do you treat it? Yeah, depending on like if it's related to
Strep.
antibiotics, blood pressure medicines, dialysis if you have to, diuretics. See what else we got here. I think I pretty much covered it. I think we talked about the diabetic nephropathy, which is basically what I explained, that the diabetes causes the glomerular problems. That's diabetic nephropathy, the microvascular deterioration from the inability to filter, from the sugar being so high, and what's the early sign symptoms? Albuminuria. Yay, good job. I don't think there's anything else.
So does the albumin, when this happens, is it low because they're excreting it?
No, the albumin. Sorry, like in the pee, you mean?
For the urinalysis.
There will be albumin in the pee,
Right.
where there's not supposed to be.
Right, and she says like the serum albumin
Will be low.
Okay, so
'cause that's in your
it's
bloodstream.
because they're like
Yeah.
secreting so much of it.
Yeah, because you're getting rid of it because it's coming out, right? And so like your body is not going to have as much left in the bloodstream. So low serum albumin is different than high urine albumin. Yeah. Does that make sense? Any other burning questions? Did we pretty much cover most of it?
Yeah.
Was it overwhelming or was it make sense?
It makes sense.
I can't tell. Sometimes I feel like I talk fast. So. That's why I make myself write stuff on the board too, because it makes me slow down. I guess I can stop the recording. Anything else before I push stop? 3, 2.